Good morning, all. At the outset, I would like to thank to the executive bodies, GSI, for giving me the scope to chair this session. So, after a deeply moving session by Dr. Purnima, the next session is on polypharmacy, that is medication management in the elderly. Before we start the session, I would like to pray the Almighty to give the courage and stamina to manage her crisis in spite of the cloudy and dark night, dark time. She should shine with the blessings of Almighty. This is my prayer to the Almighty God. The session is medication management in the elderly, and our speaker is Dr. Sandeep Tamane. He is the consultant physician and geriatrician, Dinanath Mangeshkar Hospital Research Center. So, welcome, sir. So we can start the session.
Good morning, everyone, and sincere thanks to the National GSI and the local organizers, especially to Dr. Sajesh for giving me this opportunity. I'm very happy to see my teacher, Dr. Yevlekar sir, in the audience today. So after that very touching talk, we come to a slightly different topic and a very relevant, clinically relevant topic that has been given to me to address polypharmacy challenges. So I begin with this particular line, which all of us should remember. Every ill does not need a pill. This is very relevant, especially in geriatric practice, that so many diseases, conditions can be managed by non-pharmacological measures. But we obviously have to give drugs, and we'll see over the next 20 minutes how we can minimize polypharmacy and do correct prescribing. So what is the importance of regular medication review in older people? We all know that comorbidities increase with age. They have more chronic diseases. And most important, a lot of physiological changes that occur as we age. We know what is pharmacokinetics and what is pharmacodynamics. In our medical school days, we were taught pharmacokinetics is what the body does to the drug, and pharmacodynamics is what the drug does to the body. So both these changes are very relevant in terms of prescribing medications in elderly. So what happens with these two problems? Obviously, there is increased risk of polypharmacy. There are drug interactions, adverse drug reactions, prescribing cascade. This is a very, very important thing that I would like to mention in my talk. Poor compliance, obviously, if there are too many drugs that the elder person has to take, and potentially inappropriate prescribing. So in next 20 minutes or so, what I'll discuss is what is polypharmacy, why are elders more at risk of polypharmacy and ADRs, what are the consequences of polypharmacy, and we as geriatricians, what can we do to prevent or reduce polypharmacy. So polypharmacy typically means use of multiple medications, typically 5 or more. We know many of our patients are on 10, 12, 15 medications. And I'm going to show you a prescription of my own patient. Also, polypharmacy means use of inappropriate medications or more medications than clinically indicated. There is higher probability of serious adverse effects requiring medical attention. And we clinicians often find that the adverse drug reactions account for a significant proportion of emergency room visits and hospitalizations, and many could have been prevented if they had been identified earlier. We learned from Professor Gadesh's talk about how hospitalization can be harmful to our senior citizens, and I think one of the ways is to reduce polypharmacy to prevent or reduce the hospitalizations. So this is the prescription I was talking about. This is a true prescription of one of my patients, and I am showing it here with his permission. He is on 16 drugs, and if you see, there is duplication. There are too many multivitamins. There are a couple of antacids. So these 16 medications, if you see, only 4 or 5 are really needed. His antidiabetics, his antihypertensives, his statin, and maybe one of the vitamins. But this is what he was taking for nearly 3 to 4 years before he came to me. So why are elderly at risk of polypharmacy? So we'll discuss about pharmacokinetic and pharmacodynamics. Multiple pathologies we have discussed. They have too many comorbidities, so many drugs are added. Over the counter medications is a practice in India, so that increases polypharmacy. And multiple providers, as we can appreciate, our senior citizens see many doctors. They see physician, they may see urologist for their prostate, they see a neurologist, gastroenterologist. So each one adds a drug, and the list goes on. And unfortunately, we are not very keen to stop the medications which have been started by our colleague. So this list goes on, and patients keep on taking too many drugs. So this is a brief chart about pharmacokinetics. I'm not going to go into the details of that, but so many changes occur in our body as we age, and all these affect the pharmacokinetics and the drug handling. So what are the pharmacodynamic changes? As I said, pharmacodynamics means how a drug affects the body. It can affect body's response to drugs. It is also affected by receptor binding, post-receptor effects, and chemical interactions. As we discussed in the morning, the functional reserves decline with age, affecting many organ systems, and this leads to exaggerated drug effects. So some of the examples here, very commonly used drugs. So senior citizens they have increased sensitivity to drugs like benzodiazepines, anesthetic agents, opioids, certain cardiovascular medications, and even anticoagulants. Here we also see decreased effects of certain drugs like beta adrenergic agents, and hypoglycemia is more common with glucose lowering agents, and sometimes it can be difficult to recognize or it can be even life threatening. And of course, there is increased sensitivity to anticholinergic drug effects. Many drugs that we use, like antidepressants, anti-Parkinsonian drugs, they have anticholinergic effects, and sensitivity to these side effects increases. This we've discussed, so I'll skip this. Now, this is one important topic or part I want to discuss is prescribing cascade, which we often unfortunately do. So what is prescribing cascade is we use a drug to treat the side effect of a drug. So we are doing a double crime here. So I can give some examples. So ibuprofen, it can cause hypertension if you give on a longer period. And rather than stopping or reducing the dose of ibuprofen, if you give them antihypertensive, I think you're doing a big blunder here. Similarly, amlodipine, all of us are using amlodipine, and almost everyone who is on amlodipine gets some leg edema or ankle edema. And in fact, I say that one of the ways to identify whether the patient is compliant to amlodipine or not is to look at his feet. If there is ankle edema, then I make sure that he is on amlodipine. So whenever someone has leg edema because of amlodipine, giving furosemide Lasix is a big mistake that we are doing. So we should understand that the edema is because of the drug, and the drug dose should be reduced, or the patient should be reassured. Similarly, few other examples I have put here. So the message here is very clear. Whenever you see any new symptom or a sign, then first try to identify or make sure it is not due to some drug that you are using, and don't use another drug to treat this new symptom. This is one of the ways to reduce polypharmacy and problems in elderly. Now, we also have some drug disease interactions. So if you give anticholinergic drugs to someone with dementia, they may become delirious. If you give antipsychotics to someone with Parkinson's, it can increase or worsen the symptoms of PD. So a lot of these common clinical examples I have given you, very common situations in clinical practice. So we should understand that there is something like drug disease interaction also. Then many geriatric presentations can be because of the drugs. Falls, cognitive impairment, incontinence, constipation, delirium, diarrhea, all these can occur because of many drugs. Now, what are the consequences of polypharmacy? As we say, the compliance goes down, there is increased risk of adverse drug events, impaired balance and risk of falls, cognitive impairment, drug-drug interactions, urinary incontinence, and of course, increased health costs. So overall, polypharmacy is associated with increased morbidity, mortality, and admission in senior citizens. So how can we reduce polypharmacy? So we need some screening criteria to help identify the PIMs, or say potentially inappropriate medications. So this was a very good paper from American Geriatric Society. There were guidelines which were updated in 2023, AGS Beer criteria for potentially inappropriate medication. So this is a very good criteria, and this was initially given in 1991, and initially it was only for the nursing home residents. But there were so many updates in the criteria, and now it is used for all elderly people. And they have divided the drugs into 5 general categories. So medications which are considered as potentially inappropriate, then medications which are inappropriate in patients with certain diseases or symptoms, then medications to be used with caution, potentially inappropriate drug-drug interactions, and last one is medications where the doses has to be reduced or adjusted based on the renal function. So under each category, there are many drugs. The list is very big. So we can go through the list and practice it. So the intention of this criteria basically is to reduce the older adults' exposure to the potentially inappropriate medications by improving the medication selection. It also helps to educate the clinicians and patients. It serves as a tool for evaluating the quality of care, cost, and patterns of drug use in older adults. And the criteria, they are intended to be applied or used to adults above the 65 in all ambulatory patients, acute and institutionalized care settings, except hospice and the end of life care settings. So we should know this criteria and try to implement in our clinical practice. This criteria, STOP and SMART, is used mainly in European countries. So they also have given certain guidelines. Now, what can we do to reduce polypharmacy? So as I said in my first slide, try to use non-pharmacological measures as far as possible. Then we should have clear record of all the medications which patient is taking, not only allopathic but alternative medications. We should identify all drugs by generic name and drug class. There are so many trade names, so sometimes it is difficult to know what exactly this drug contains. Make sure that the drug being prescribed has a valid clinical indication. Beware of the side effect profile of each of the drug given and inform patients and carers accordingly. So as I said, when you give amlodipine to someone, tell them that it might cause little ankle edema. Then understand how the pharmacokinetic and pharmacodynamic increases the risk of adverse events. We should immediately stop any drug which has no known benefit or there is no clear indication, and attempt to substitute less toxic drugs and at lowest possible doses. Now, I told about prescribing cascade. So please remember about this. Do not use a drug to treat the side effect of a drug. And as I showed you in my prescription, make sure there is no duplication of the drugs. Make sure there are no two sulfonylurea. Sometimes there are patients who are on glimepiride and gliclazide both by mistake. So I think as clinicians, we should check the prescriptions carefully and avoid these blunders. So simplify the drug regimen. So give them once a day pills rather than giving them 3 times a day, 4 times a day. Use combinations. We can use extended release or long acting preparations. And polypill concept is now being used. It is very useful to cut down the pill burden and improve the compliance. So we should also have proper discussion with patients, carers about the goals of care, how aggressive we want to treat the patient, what are the goals of care, what the family wishes, what the carers want. It is very important to involve the family physicians and pharmacists in deciding the medications. And most important is to individualize the treatment goals, especially for patients who are frail or very old. So this is also an important thing that we should remember. Now, this brown bag concept is very important. What it means that whenever a patient comes to you in your clinic, he should bring all his medications in one brown bag. There may be tablets, there may be ear drops, eye drops, inhalers, ointments, whatever he is taking from all pathies. He should bring all those with you. And as a clinician, you should check all those medications and make sure that these are indicated and to stop which are not indicated. So I think we should start practicing this brown bag concept. And this was told to me by one of my teachers in UK. He said, a good geriatrician is one who stops more medications than what he starts. And now, with so many years of clinical practice, I understand how correct he was. But I'm not giving a wrong message here. Please encourage your patients to take the medications when they are indicated, especially when they are life saving and indicated drugs like their antihypertensives, anti-diabetics, aspirin, statins, etc. I think I will stop here. I'm in time. Thank you.
Thank you, sir. Thank you for this very practical and clinical balls. It's actually very common problem for these geriatric people to take so many of medications, and also they are also confused, and their caretakers are also confused how to take, when to take the medicines. So your talk is very much helpful for all of us clinicians. Also, we could one thing I can say that. The poly pill, the combination pill, and we should we should counsel the patient and their attendants for we should make a table on how to take and how much tablets to take, how much drugs to take, and when to take, so that they will not be confused, so that the side effects of the drugs because of confusion is also very much high nowadays because of the unawareness. We should clear that also. Thank you, sir. Thank you for such a vast and enlightening talk, sir. Any questions?
Please, please.
Thank you, Dr. Sandeep.
Thank you.
Wonderful talk. The only problem today's time is that in the elderly, when there is multiple systems are involved, and all physicians, or I should say the super specialist or the sub-specialist, they have a tubular vision. Though they don't have time to see what the patient is actually taking and what for. This is number one problem. Second problem is that with lot many pharmaceutical companies, local companies, national, international, multi, they have the drugs with different names. So that again becomes difficult to find out what is the composition of this particular drug or the pill. And the third thing is the time constraint, which every physician has. So my suggestion is that if we really want to treat these elderly people, I will not say the patient because they are people, we should have a physician assistant with us. And before the patient comes to your chamber, he should analyze everything about what the patient exactly is taking. He should make a list and find out from the Google or Internet Explorer what is the content of this particular medicine he is taking, so that it is time saving and the precious time of the physician is in taking care of the patient, making a rapport with the patient, counseling of the patient. So this is one suggestion of mine. I don't know how many can do that or not. Thank you very much.
That's very correct, sir. I think the time constraint is the problem, but we can overcome that. As you suggested, we can have more assistants who can go into the medication list and guide us accordingly.
Thank you for the nice talk. Very practical. One or two comments. People always talk about long-acting drugs so that there is a dosage advantage. Especially in the case of diabetes, you try to use glimepiride and glibenclamide as it is promoted as single-dose convenience. But then, especially in the elderly, it's better to avoid long-acting drugs. When you want to treat a diabetic, I would say glipizide, which is given 3 times a day, not the long-acting preparation, which is useless, is a better drug than glimepiride. We have seen so many patients taking long-acting drugs, missing meal and developing hypoglycemia. As we always say, hyperglycemia is better than hypoglycemia.
Yeah,
if you have a choice.
Yeah.
So shorter acting drugs will be a good option in any case, even for diabetes and other things, for old people. The promotion of long-acting insulin, long-acting drugs is just for the executives who travel so that they don't get the time to inject. All these are not practical for an elderly person who's sitting at home. And by using shorter drugs, shorter acting drugs, 6 hours action, 8 hours action, we actually prevent a deadly complication, that is severe hypoglycemia. This is one. Secondly, as we already mentioned, alternative medicine is interplaying with our practice. We don't know what they contain. We don't know how they interact with our medicines. Always, that is always mentioned. And there are things which are apart from alternative medicine. We have alternative systems practitioners in yoga, exercise, and in Kerala they have something called Kalari. All these are dangerous. They break bones and send the patient to our clinic. So alternative medical practice and alternative practice, they are all dangerous. That's what we observe. Thank you very much.
Thank you, sir. So it's a real challenge for the physician as well as the patient to stick to the right drug in right time. So better to choose a fixed drug combination and also keep in mind the drug-to-drug reaction also. So thank you, sir, for enlightening all of us regarding
Thank you.
polypharmacy. Now we will wind up the session. Thank you.
Thank you, sir. Thank you, sir.